Okay, so I'm gonna go first then. So good evening, everyone. So how we're gonna proceed tonight is that I'm just gonna give a brief introduction by way of showing some cases to generate some discussion. And then Fidelis is gonna give his presentation on bone grafting, and Nicola will do the synthetic substances. So, I mean, the whole idea, for these Tuesday night discussions is not meant to be extremely didactic. So I try and keep it, practical and case-based. And certainly that's sort of the kind of preparation you should have, because anyone can pick up an article and go read it. So the whole idea is that it's just meant to reinforce what you will have read on your own. And also, like I said, show a few examples here and there. So without wasting much time, I'm going to get started. Let's see if I can still do this. Okay, so question for you, Ramon. So microphone on?
Prof, yeah.
Good, that's your first question on the screen. So what's the commonest tissue transplantation procedure in the world?
It's a blood transfusion.
Okay, microphone off. Let's go to Cindy. Cindy, what's your answer?
Blood was a good answer, but I would go for skin.
Okay, skin graft. Dane?
I mean, Prof, I'm going to have to guess bone grafting, given the nature of the topic.
Okay, so it's a good thing you don't play the lotto. Brad?
Oh, I think those are the three good options, Prof. I would also go with bone grafting.
Okay. Lastly, okay, Mkize, let's see if you can come up with something more.
Nah, I was gonna go with blood, Prof.
Okay. Yeah, so that's the correct answer. So the commonest transplantation in the world is blood transfusion. But now, what's number two? It's bone grafting. So the 2 million bone grafting procedures that are performed annually, around the world. So it's not an uncommon procedure. And so I've got a few, like I said, just some case examples to show. So I'm gonna pick on Wazima. So that's your case coming up.
Yes,
so look,
Prof.
just try and keep it, keep it flowing forward. Don't waste too much time, okay?
Yeah.
Right, so that's your case. So, polytraumatized patient. I just put the humerus up just to complete the discussion, or rather to complete the clinical picture. But how would you treat the femur? What do you see there?
So on the femur, I see what looks like a bifocal femur fracture, subtroch as well as a mid-shaft femur fracture on the right side. Yeah.
So yeah, and when you see that, you've done orthopedics for at least 3 or 4 years now, and you've seen a few polytraumatized or bifocal or segmental fracture patients. What have you gleaned over the years when it comes to these problems?
What have I?
Just over the years, what have you learned? What have you learned to fear when you see that?
Yeah. It's just have to. What I've learned is, the approach to when you presented with the problem like that, how to approach to solving the problem in front of me. So obviously it will be your same approach of ATLS and all that, but coming into the femur itself, you need to have a device that's going to address both fractures at the same time, if possible, of which in my hands looks like it would be more amenable to a cephalomedullary nailing.
Hey, so I don't think anyone will disagree with that. And I think for the people that often say, you should consider 2 devices, that's of course when both devices are an option. But for a subtroch like that, DHS isn't really you know, a viable option. So DHS plus a retrograde nail. So yeah, that's what you're faced with. So a proper subtroch with an associated shaft, like Wazima said, and that's what was done. And you will see obviously that she disappeared for a while because she came back with the stitches or with the clips still in place. And so what's going on here? Okay, fine. Wazima, you can switch off.
Okay.
Let's go to back to Scout.
Yes, Prof. So you can see that it's got a capillary nail fixation. The diaphysial. Sorry, so the diaphysial fracture looks united on the different views, but there seems to be a non-union of the subtrochanteric fracture.
Is it really a non-union? I mean, you say she's still got clips on.
True that I don't actually know the duration specifically, but yeah, there are still clips. But I would expect if there's a union of the shaft, that it's at least a few weeks down the line.
Okay, so when you see that, what do you tell her?
So you tell her that, well, depending on the time frame, you'd say that there could still be a chance of union at the subtrochanteric area. If there is a prolonged time, then you might have to say that there's need for a second procedure, or maybe removal, depending on your implant, maybe dynamization of the implant, removal of the distal screws, or revision of the fixation device itself to allow a biomechanically more stable environment for fracture to heal.
Okay, so that's what you tell her, but what do you tell yourself? What's your inner voice telling you?
The inner voice is a bit stressed, because you know that you now have a fracture that hasn't healed, that you need to allow it to heal without risking complications or further complications and sepsis. So you know that you'll have to improve the biomechanical environment, but you also might have to consider bone grafting, whether it be auto or allo or synthetic kind of bone graft, to give the fracture its best chance to heal. So you can do it basically in one sitting.
And what's your worst fear?
Is that it either still doesn't unite, or goes septic and also doesn't unite.
Okay, and if it doesn't unite, what's your worst fear?
My worst fear would, if it doesn't unite, maybe of the implant failure, on breaking, and the need for a difficult retrieval or removal of the hardware, or that patient doesn't trust you the next time you're there.
Okay, so your fears have been realized. So that's what's happened. Cindy?
Yeah, no, it's worse now.
Okay.
Yeah, it's definitely worse. I would have said my biggest fear was a septic non-union, but after looking at this now, this is definitely worse. You've got hardware that's broken off. To go and take that out is going to be very difficult. It's made everything more difficult now, because you've got a fracture still, you've got broken hardware, plus minus, I don't know if she has infection or not. Everything needs to come out. You need to do a new implant. In the initial x-rays, if you looked at the initial subtroch fracture, it was the bone there kind of looked, I don't want to say pathological, but it looked like the bone there was a bit hypodense.
No, it's not. I can tell you, it was entirely normal. It's just the pixelation on the photos.
Okay.
Okay, so she's now got a broken implant in the non-union. So what are you going to do for her?
So now we need to first optimize the host. We need to work her up, and then we need to plan how to go and take this implant out. Because the bone is broken there, at that point, I think you will be able to take out the screws in the neck. I think they will be okay. But I will order everything, the sets, the broken screw removal, everything. And then once you've got the implant out, you will have to fix with a new implant. But at this point, I would definitely consider some other substitute, be it a bone graft or antibiotic, synthetic bone graft,
She's not
cement, or
infected. She's
something
not
like that.
infected. She's not infected. So no antibiotics required.
Not infected. Okay.
So let's just go back. So you want to, so there's two things that you want to do now. You want to correct the biology, at least to improve the biology, and you want to improve the mechanics, right?
Mm-hmm.
So how are you going to improve the mechanics?
Okay. So one, by taking out the entire nail, and then I would ream and try and put in a larger nail.
Okay. So that's how you're going to improve the mechanics, larger nail. How are you going to improve the biology?
This I can do with a bone graft.
What kind?
Autograft, the patient's own, from either the iliac crest or, yeah, ideally.
Okay. Let's go back to Skalk. What do you think of the biology option?
Sorry, Prof, you mean in terms of the autograft?
Well, Cindy wants to change the nail and then do autograft, but her autograft is going to come from the iliac wing.
Yeah, so the iliac wing is normally, you could use it for a structural bone graft. It gives you the tricortical benefit. But I think in this case, if you're doing an intramedullary fixation device, and you have good bony contact, and no bone defect to address, then you probably don't need iliac crest. You could, from the contralateral femur, you could use a RIA, reaming irrigation aspiration system, to get some autograft from there. You could also consider proximal tibia, maybe just metaphyseal bone graft.
Stop there. So you mentioned RIA. So I mean, remember that you have to do these things in steps, and also so often, I say what we do is mostly, based on science and a little bit on art and some philosophies. But I mean, science is very clear on this. What is the gold standard for treatment of an intramedullary or of a femur nonunion with a nail?
So that would be reaming and increase the size of the nail and add stability. So you can also augment even with a plate if you have to, but that would be
leave the augmentation. So I think if you're gonna go like in steps, the gold standard for a femur, non-union with a nail is exchange nailing. And what does exchange nailing offer you? It offers you a larger implant, which improves your biology. What else does it offer you?
It offers you the new reamings of that bone.
Yeah,
Do you want to use the reaming primarily?
So the reaming provides the autograft and the stimulation that you're looking for. So that's the next phase in your approach. So yes, of course, there's many things that you can do when your plan A and your plan B don't succeed, but you don't immediately go to like RIA of the other side now. I mean, I'm going to ask you now, Skalk, how many RIAs have you done from the other side?
just one, Prof.
Just one, and now suddenly you think that's the gold standard because you've done one. Okay, so it's not. Look, again, it just takes you back now to how we answer questions on Monday morning, that we don't skip to, or rather don't think that, the question is there to trap you or to catch you out. So learn to go through your systems first and have a stepwise approach. Okay, so that's the first thing that I wanted to demonstrate in terms of the discussion for tonight is autograft and how to obtain autograft. So you can obtain autograft from reaming. So the misconception is that autografts only come from, bone that's harvested from somewhere else, but I'll leave that part for Fidelis. Okay, anyway, we'll move on. So we did exactly that. Wider nail, change the nail a bit because there's now a big hole in the femur. And we've now got a wider nail, we've got a different screw, and we've done reaming. So now we've got bone grafting in place. And then that's what happens. So I'm gonna go to Dane.
Yeah. So plan B has failed.
Yeah.
And this nail prop was put in without any additional bone grafting, just the nail
Now, well, just the nail and the reaming. I mean, that's
and the reamings.
That's the correct, step after the failed nail initially. So now you've got this.
So, I mean, Cindy's already said it, but we need to optimize the host, although she did show that she has potential to heal with the diaphyseal fracture. And the principles were followed with regards to exchange nailing. As you said, they did upsize and they reamed, although that just on eyeball doesn't look like the biggest scaphomedullary nail that you could have put in. But yeah, starting from the beginning, host optimization, the nail needs to come out. And I still believe it would be best treated with a nail. However, this time I would seek bone graft from elsewhere. In our setting, autograft would be the what we would use, and then I would upsize the nail if possible. And as Skalk mentioned, you could consider augmenting with additional fixation in that area, and you want to achieve compression.
Like, in all honesty, I don't see how you're going to upsize that nail, because that's the widest proximal diameter you're going to get, and it's broken right through that. So upsizing it,
Yeah,
they upsize the shaft, but remember the proximal
yeah,
diameter
that's what I meant.
is the same. Okay, so
Yeah, okay, fair enough.
yeah. Also, I mean, you've done the nail 2 times now, and it's failed. So I think your trust in the femur nail has to be questioned. Idilis?
Yeah, Prof, I think, as you mentioned, they've tried to nail twice, changing the types of the nail, but still it has broken. So I think in my hands, the next option here will be probably try an onlay device, a proximal locking femur plate, and then I'll possibly also do local bone grafting, so cancellous bone graft. Yeah, that would be my option. Yeah.
So when you say local bone grafting, where's the bone graft coming from?
So I'll do cancellous bone grafting. I'll probably have some iliac crest cancellous bone, and then I'll do grafting.
Okay, so there's, basically again here, the principles remain the same, that we need to improve the mechanics and we need to strengthen the biology. So mechanics, we've tried the femur nail twice and it hasn't worked. And you've tried, autogenous from the reaming, hasn't worked. So now next step is going to be exactly that you need now to look at other ways to provide your bone graft, and you need to look at other ways to provide your biology. And ultimately that's what we did. So took the nail out, auto grafting from the iliac crest, and compression plating. And eventually she went on to union. So that's just demonstrating one way where bone grafting is going to, is going to get you out of jail. Okay, so next case. I'm just going to discuss this one. So he's a 47-year-old. Now I saw him in Paloti, and he's been paraplegic for the last 25 years. So wheelchair bound, and so also quite osteoporotic, that when his helper was trying to transfer him from his wheelchair onto his bed, just by lifting the legs, fractured his tibia. And look at the proximal aspect of the tibia. He's just got no bone there. It's basically hollow. So a guy like this is at risk for fracturing. And so luckily for the tibia, he went on to unite, and then comes back now after a fall. So he fell off his wheelchair, and that's his AP pelvis. And of course, the funny thing is that this we thought was new, but he actually remembered a fall a few weeks earlier. So this was not new, even though you see that pain there, but looking at that, it looked quite chronic. But importantly, he comes with this. So he's got bilateral distal tibia fractures. So Hamad, I'm going to come to you now. So put the child down.
Prof, unfortunately, I don't have the kids with me now, so that's fine.
Oh, I'm looking at the photo, sorry.
So in this patient, so we can see the patient is severely osteopenic. from his previous x-rays, and the current ones we have here of the AP and lateral of both distal femurs and proximal tibias. First thing I'd like to know is, did you have an appropriate workup and endocrine review to find out the exact cause, and if he's on treatment for his osteopenia? Because obviously we'd like to prevent these from happening in the first place. And then, was there good education at the nursing home in terms of how to appropriately care and move this patient around? Because obviously if they're lifting him up on a long lever arm instead of carrying him at the hinge sites, he's going to fracture quite easily. Then we have to see his current activity level and what he is able or not able to do and how functional he is. Is he able to transfer himself from bed to wheelchair on his own? Because we want to get him back to that level.
Yeah, he does. I mean, with a little bit of assistance, but I mean, like I said, he's been paraplegic for over 2 decades, so he's as functional and as rehab as he's ever going to be. But he does require assistance.
So I think our main aims here will be to manage his pain. In terms of his tibia and his bilateral distal femur fractures, my feeling is that those potentially we could treat not conservative, we can treat that with prolonged immobilization in plaster casts. But the hip fracture, I think, will need to be addressed because that will be his maximum point of pain. In this case,
hip fracture is not new. Look, if you look at that, that's not new. So it was missed and it healed in that position.
Okay, so depending on his pain level on the hip, we could potentially just leave that. And then for his distal femur fractures, I mean, to plate these in a severely osteopenic bone like this, there's a high risk of complications post-operatively in terms of hardware failure with screw pull-out, etc., with not enough purchase. But then we also have to weigh up the complications of leaving him immobilized in bilateral pops and risk of DVTs, etc. However, in this position and the potential for healing around the metaphyseal area, we may then elect to, my feeling initially is to not go and fix these and treat them in a conservative way. Because he's a paraplegic, you could potentially try ROM, range of motion braces locked, and then a gradual increase in motion over a period of time. That way we may still be able to avoid the other risks of prolonged bilateral above knee POPs.
So I mean, remember, of course, that's the exact discussion that you need to have with him. But I think, practically speaking, how easy is he going to be to nurse in bilateral range of motion braces? And also remember that he came because he's in pain. You know, as much as he's paraplegic, you do experience pain, and if you don't act on the pain and there's motion at the fracture site, then they get sympathetic dysreflexia. And also, how immobile are you going to get him in that range of motion brace? So I think you have to think that you're setting him up for a non-union. Also, because he's got no bone, no bone architecture there, so there's not much to work with in terms of healing.
So then after consultation with the patient and going through all of those and seeing his pain level, then the option would be for bilateral locked distal femoral plating with the maximum number of locked screws in that metaphyseal area, and then also potentially just locking this plate completely in the diaphysis and metaphyseal area in severely osteopenic bone, and then making sure he's on appropriate treatment for his osteopenia to assist with future fractures and bone healing at this time.
So when you put your locked femur plate, you have to be plating into something. So you're going to have your maximum screws in the box, like you said. What are they going to purchase? What are they going to be purchasing onto?
So we can augment that fixation similarly like we do in the hip. So we have a few options. We can use products. We could even fill that metaphyseal area with cement and then plate through that, and use other adjuncts such as calcium phosphate, I think, in that area as well. And there's other products, can't get to the name now exactly what they are, but certain companies do offer other bone filling augments that you can use in the metaphyseal area to provide more purchase on your distal femoral locking screws. And then just to make sure your construct of the screw, so with different plates, You'd use the fixed angle locking plates to avoid the risk of converging your screws in the metaphyseal area. So you just make sure that your screws are divergent as best you can. And then you just hope that your plates don't pull out over time.
Oh, that's fine. Look, I think, I mean, if I can just add on to your answer, I think, I mean, for someone who has a tax tonight, you know, on bone graft and substitutes, I expect you to have all the terminology, you know, coming out of your mouth. You need to be prepared for the tutorial. So know what calcium phosphate is, what calcium sulfate is.
Yeah, calcium sulfate.
Okay, because I mean, like I said, the whole idea is not to spoon feed, so you must come with your knowledge at hand, and then we can discuss around that.
Yeah.
Anyway, so that's what we did. So we had to, like I said, just augment the, you know, the bony box with a substitute, just a synthetic substitute, just to at least to get, you know, something to, you know, for the screws to bite onto. And the proximal non-locking screws, that hole is not a hole, so there's not meant to be any screws there, but figure that, you know what, it's there, and you can squeeze an extra screw, and that's what I did. But I mean, the main fixation comes, like you said, from the fixed angle screws and the locking screws in the shaft. So that's another application of bone substitutes. And then the other scenario, I mean, look, I'll just go through this quickly so this can start. So I mean, we've seen this often, and you know, in osteoporotic or osteopenic patients, and there are many reasons for this. And so often, of course, is poor placement, but sometimes, you know, it just comes from poor bone quality. And what you need to have, certainly in the elderly, is to use, you know, angular stable constructs, but importantly, you need to respect the tip apex distance. There was not a lot of discussion and research on HA-coated screws previously, but these have sort of lost favor. And what matters more now, like I said, is placement. But there's an opportunity for cement augmentation in patients who are extremely osteopenic, osteoporotic, or you worry about hardware failure. And this is just an example of a, you know, PFNA that allows you to inject cement through the screw, the case I did a couple of years ago. And so how it works, so you've got your PFNA blade, which, as you know, is fenestrated, and then the kit comes. So the only thing you provide is the dye that you need to inject. I'll show you now how it works, but there's a whole kit that comes separately with the cement. So once you put your guide wire in place and you're happy, then you put your screw in, and compression, then you inject the dye. So the whole idea is that your dye, it mustn't penetrate the cortex or the femoral head, because if it penetrates the femoral head or it gets into the capsule, that's exactly where the cement is going to go. And of course, this is the discussion that Nicola had a few weeks ago, the two kinds of cement, when you want it to set, fast setting or slow setting. So in a case like this, it becomes important. So inject your dye and make sure that it stays within the femur head and neck. And if it does, then you mix your cement, and through the blade, you can then inject, and that's the cement going into the head. Okay, it looks like that when it's done. So it increases your pull-out strength, and thus improves your construct. One thing to warn you about, if you penetrate, because some people will put a guide wire into the femur head, past the head into the acetabulum. If you do that and you inject, the dye will go through into the joint, and that's exactly where the cement is going to go. So do not do that. If you penetrate the femur head, then you can't use the cement. Okay. And then lastly, I don't know if Nicola will touch on this. So I've got these two gentlemen here, and then the imposter in the middle. So on the left, that's Alvin Crawford. Brad, who's Alvin Crawford?
I don't know, Prof. Sorry.
Anyone knows? Who's just done pediatric orthopedics? Maitland Cottage.
Yeah, that's me. He wasn't mentioned.
You did not read. Neurofibromatosis. Who classified neurofibromatosis? one of the classifications. Yes, that's disappointing. But anyway, he is one of the, gurus of neurofibromatosis and thoracoscopic surgery in children. But importantly, the guy on the right, he's probably the most accomplished person I have ever met in my life. So his whole thing is that he invented the field of regenerative engineering. And so both of them were honored at the American Academy meeting last year with Lifetime Achievement Awards. So the whole field of, so what is regenerative engineering? Nicola, I'm going to touch on that. Am I stealing your light here?
No, Prof, not at all.
Not at all. Okay. So I said it's a whole new field that he invented himself. And basically, it's the amalgamation of tissue engineering with material science, stem cell biology, and developmental biology. So all those things come together to basically form. So you can use it in bone, you can use it in any kind of tissue loss. It can be any kind of tissue. So do yourselves a favor, and I'll give you the name one more time, Katie Lorenzen. Google him and Google what he's done, and you'll be mighty impressed. Okay, so I'm going to leave it there, and look, there are of course articles available that you can read for your own benefit. Just that summarize the bone graft and substitutes for you. But like I said, the whole idea is not to spoon feed you, but those are the ones that I found when I was doing my refresher course. Okay, so without much ado, I'm going to hand you over to Fidelis. Okay, so Fidelis, you can share your screen.
Okay. I don't know if you can see my screen.
Yes, we can, yeah.
Okay, all right, cool. So I'm just going to talk about auto, allo, and xenografts. I think I didn't go into detail in terms of indications when you can do this bone grafting, that's auto, allo, xenografts. But I think some of the indications, Prof has sort of mentioned some of them. So I'm just going to start with a bit of definitions. So I think it is words that we have heard before: osteoconduction, osteoinductive, and osteogenic. I think if you're talking about bone graft, you need to have kind of like have an idea of what these words mean. So osteoconductive, conductive, it's a word we use for materials that have properties of ability to provide a structure which serves as a support for cells to migrate from the host and then differentiate into osteogenic cells. And then osteoinductive materials, these are materials that have the ability to induce differentiation of mesenchymal stem cells into, in this case, into osteoblasts, which then form bone. And then osteogenic materials have this ability to form bone. So it's materials that actually have living osteogenic cells like your osteoblasts. So if you graft these osteogenic materials, they'll be able to form bone. And then in terms of grafts itself, the autografts, so it's considered the gold standard for bone grafting. And so it's basically when you do an autograft, you are transferring bone from one body side to another body side in the same patient. And then they come in different types. So it can be cancellous, it can be cortical, or it can be vascularized or devascularized cortical grafts. And then also this category also includes your bone marrow aspirates as well. And then your rima aspirata irrigator, which we sort of briefly described and talk about earlier on. Okay, sorry. So a little bit about cancellous autografts. So in terms of their properties, they're mainly osteogenic, osteoconductive, and osteoinductive. These grafts contain mesenchymal stem cells and also some proteins, which include bone morphogenic proteins. which are pro-bone formation. And then they also provide a 3D scaffold for osteoconduction. And cancellous bone grafts actually has greater surface area compared to other autografts like cortical bone. And then good thing about cancellous autografts is they integrate quickly. And histological studies have actually shown that within 48 hours, you already have growth of new blood vessels from the host bed into the cancellous autograft. But note is that initially, after grafting them, they actually provide minimal structural support. So normally these cancellous autografts, we use them in mechanically stable environments. For example, in your tibial plateau fractures that you have fixed, and then you use cancellous bone graft to fill the void. And then other type of autografts is your cortical bone grafts. So these ones are less biologically active compared to cancellous autografts, and their integration takes longer compared to cancellous. But good thing is they do offer more structural support. So because of that, they are usually used to span larger defects, which needs also a mechanical structural support. Good examples is your vascularized cortical grafts, for example, your fibula and your ribs, and also distal radius that can be used as well for scaffold fractures. So they're quite good in terms of even though they take long to integrate, but they offer immediate structural support to where you're grafting them. And then a little bit about these autografts. So there are pros and cons to using autograft, and the biggest thing is donor site morbidity. So depending with where you harvest the autograft, there are like complications that you get in the acute phase and then the long-term complications. And in terms of your acute complications, things like infection, formation of hematomas, acute fractures, and also like in terms of your long-term complications, you can have ugly-looking scars from your donor sites, as well as some patients will complain about chronic ongoing pain, which can make patients quite unhappy, even if the primary problem that you are addressing has been fixed. And then the other big issue is limited supply. So if you need a significant amount of bone graft, there's sort of a limitation in terms of how much you can harvest as autograft. But of course, the benefits, as mentioned earlier, early integration, and then there's also no risk for disease transmission, which we'll talk about when we talk about allograft just now. And then going to allograft. So by definition, allografts, just got this definition from a WHO website. So it's basically a transfer of an organ / tissue cells from one individual to another of the same species, but not necessarily identical twins. But in this case, of course, we're talking about bone. So usually, it comes in different forms. Allografts can be cortical bone, it can be cancellous bone, or it can be osteochondral grafts. And these are usually, osteochondral grafts are usually used for in oncology when they're doing like distal femur replacements and stuff like that. And then it also differs in terms of how it's processed. So you do get fresh allografts, and then you get frozen, freeze-dried, and demineralized bone matrix. Fresh allografts not commonly used because of the risk of disease transmission, as well as availability. But frozen and freeze-dried, in our case, most of the time we are using freeze-dried, which is your bone chips and then etc. And then you also get demineralized bone matrix, and I'll talk about it a little bit later on. And then also they differ in terms of how they are sterilized in the two main types of achieving graft sterility. So firstly, there's terminal sterilization where you process the graft, and then at the end, after you've processed the graft, then you can sterilize it as the final stage of graft preparation. Or it can be throughout the whole process where aseptic technique is maintained throughout the graft harvesting and processing. So in terms of graft, in terms of sterilization, you can either use gamma irradiation or you can use ethylene oxide. Both have pros and cons. Ethylene oxide has been noted to cause more, affect the biologic osteoinduction capabilities of osteografts, and then gamma irradiation affects more of the mechanical aspect of the bone, of the allografts. And then also the allografts come in different packaging or handling properties. So you do get them as powder, and then in particulate form, pastes, and then chips, which is what you commonly get, and also strips sometimes as well in our local environment. And then in terms of allograft sources, the most, so this was mainly from a paper from the UK. The most biggest source for allograft is living donors. So patients who are going through total hip replacements, and then the femur heads are collected in an aseptic, after you do the femur cut, and then they collect the femur heads. And then other sources is multi-organ donors. These ones are usually like from young patients who have donated their body organs, and then the long bones are harvested during the process of organ harvesting. And then also a small percentage also is from post-mortem donors. But always the biggest concern with post-mortem donors is screening for diseases. So they use them, but most of the donations they get, they usually fall through the process of disease screening, and so they don't use them that often. And then most of these grafts, the sources, so they do pre-donation screening where they do blood testing, and they commonly test for things like HIV, for hepatitis B and C, and then some other jurisdictions, I think it's mainly in America, they also test for human T, lymphotrophic viruses, and also prions as well, but not so common with prions in bone tissues. It's mainly in subdural grafts. And then so they do pre-donation testing and post-donation testing. So they get, for example, for the living donors, they harvest the femur heads, and then they preserve them and keep them, and then so they test pre-collection, and then they also test the donors at 5 to 6 months after donation, just to make sure that there is no seroconversion in between before they can process and release the allografts. So then in terms of allograft processing itself, as I mentioned earlier, there's aseptic processing versus terminal sterilization. And then so during the early phases of processing, just removing of all soft tissues, and then sizing and shaping of the allograft. And then usually it's washed under pressurized fluids. Usually they use ethanol or acetone peroxide, and then they take out all the bone marrow, which is quite allergenic, as well as tissue debris as well. And then in terms of preservation, there are a couple of ways of doing it. So either do freezing at 0 degrees, or freezing using liquid nitrogen at -196 degrees. And then commonly they use freeze drying. That's what we commonly use here, where they dry the allograft, and then whilst so they freeze it, and then whilst it's frozen, they actually do removal of the water in a vacuum condition, and then they peg the allograft. The good advantage of using freeze-dried products is they can be stored at room temperature, and it also also have a long shelf life as well. I've mentioned this before in terms of how they sterilize them. And then a little bit about demineralized bone matrix. So it's one of allografts that we do have. So demineralized bone matrix is basically produced from removing all the mineral content from bone using acid solutions. And then what you are left with is mainly collagen type 1, as well as your bone morphogenic proteins and other glycoproteins as well. And it comes in different forms. I've seen in the images, it comes in powder, it comes in gel, as a paste as well. The thing about demineralized bone matrix is it's quite osteoinductive, and also it's also quite osteoconductive as well, but though to a lesser extent because of weight processed. And then it can also be mixed with other substances, materials like calcium phosphate, and bovine and bovine or porcine collagen, just to use it as to increase the volume of your allograft. And it's minimally allergenic, and also its use is used mainly for non-unions and lead unions. Those are the main indications, but you also have relative indications in acute trauma as well. And then there's also new indications for using it in aneurysmal bone cysts, and it has been shown that it actually may halt the osteolytic phase in aneurysmal bone cysts. Okay, and then xenografts, couldn't find a lot about it, but it's basically when you get bone graft from non-human subjects, even, for example, bovine and coral, which is mainly from the seabed. And then it's usually treated to reduce its ability to induce the host's immune response. And in terms of their properties, they are mainly osteoconductive. Yeah, that's it. Happy to take any additions, but definitely subtractions. A few questions.
Thanks, Fidelis. Look, I mean, if there's one thing I can just add on DBM or demineralized bone matrix is that, I mean, we did lots and lots of trials previously, and we have participated at Holoskia in some of them, but the results have honestly been disappointing, and we used it mostly for compound TBF fractures. So there's a lot that gets spoken about DBM, but in practical application, honestly, the results have not been as great as the theoretical advantages, and certainly not matched by the hype that was generated around DBMs. So, you know, we don't, as a result, use them as widely. I mean, there was a time, I remember when I worked in the States, basically every fracture, they would put the plate on and then pour DBM on the fresh fracture, because like that was a buzzword at the time. But like I said, certainly the results and the clinical application just has not been great, you know. And then another thing to add, which also seemed promising for a while, was platelet-rich plasma. And again, mostly experimental. It seems and sounds great on paper that you've got all these pluripotential cells like in your plasma, but many of them, or rather the results have been quite disappointing. Okay, so I think, does anyone have any questions for the first presentation or the second presentation, or anything that you want to add?
Prof, I wanted to ask, when you were showing those pictures of the cephalomedullary nail with where you injected cement into the femoral head, were those revision cases? And if not, what would make you use or do such a thing as in injecting cement when you're not doing a revision of primary fixation?
Yeah, so none of those were primary cases, not revision. So the reason was just patients were extremely osteopenic, and the concern was that, you know, because remember that the elderly cannot do touch weight bearing or partial weight bearing. So if there's any concern, there is an opportunity to use cement augmentation. We've used it as well at Hodeske, I remember, for some of the, oncology patients that are not for replacement, but are still amenable, not for fixation, but just don't have enough bone stock in the femur neck. So the short answer is, if you're concerned and you want them to start walking immediately, which is the ideal goal, then there's definitely an opportunity for primary cement augmentation. So we don't do it often, I agree, but definitely there's an opportunity for that.
Thanks.
Okay. So it really is just, prophylaxis and protecting your fixation from failure. I don't know, I'm going to put Anna on the spot here. It's obviously, I would imagine you see far more osteoporotic patients than we do, and far more elderly patients. How often do you use cement augmentation?
Hi, actually quite often, but more likely for revisions. So when a nail failed, and with very, very slow and careful injection of the cement, I've seen it working even when the blade or screw cut through the head.
Okay, no, great. And also, to go back to that case I showed initially with the failed femur nail, once you've changed your screws and we have the defect in the femur head, there is an opportunity as well to put calcium phosphate in the previous defect where the initial screws were. So that we've also done sometimes. So to use it purely as a void filler. And then, of course, over time, it gets absorbed and replaced by bone. But I'm not going to steal Nicola's show. So, Nicola, over to you.
Thank you, Prof. Let's see, where is this presentation now? Okay.
What happened? You had it on before we started.
No, Prof, I lost it. I'm just looking for it. Hold on a second. Okay, then. Wait, just hold on. Nope, not that one.
Prof, can I ask why she gets the presentation ready?
Yes, yeah, go ahead.
So just on those xenografts, I understand the concept. Is there anything like that available in South Africa? I don't think I've ever heard of that being even mentioned.
Yeah, to be honest, no. I mean, even I can't think of any application locally. I mean, has anyone heard of its use? I know, of course, I mean, in heart valves, yes. I mean, they use pig valves all the time, but in terms of bone, I honestly don't know.
I'm not sure when they stopped, but didn't at some point they use bovine ligaments or tendons for soft tissue work, like ACLs and things, like quite a while ago. Long.
Even that, I'm not sure. The only bovine we do is for, like, if they want it, like, but so often they refuse it. Also, like Jehovah's Witnesses. So I just can't think of any besides, like I said, besides heart valves. And also in vascular surgery, they use it for grafting. But I mean, beyond that, I honestly don't know.
I don't know why it doesn't want to share anymore.
Okay, there, we've got it now.
Sorry.
Yeah, we can see the screen.
Oh, you can see it.
We got it. Yeah.
Yeah, we can. But now just go into your presentation mode. You see, it's like you guys being so fancy because I could never share my screen using an iPad, so I don't even know how you do it.
Can you see it now?
We can see it, yeah, but I think because we can see the slides on the side, but don't we have a presenter mode?
I'm trying to get it to present mode, but it's just a delay. Let's see it.
Yeah, that's it. You heard it just now.
Okay, sorry.
I don't know what you did.
Just a feedback from my quick literature search is that basically xenografts are bad and they don't work well.
Nicola, you've got it.
Perfect. Sorry about that small delay. I'll be talking about bone graft substitutes. I can start off by a definition. So a bone substitute are natural or synthetic or composite material that we use to fill bone defects, and its main function is to promote bone healing. So they've got three main purposes when you use bone graft. It either acts as a linkage, splintage, or to promote osteogenesis. When I speak about linkage, it's when you fill bony defects, replace crushed bone, or it acts as an arthrodesis. Splintage is basically when you use it for non-unions or arthrodesis, and when you use it as primarily as a osteogenesis. So 60% of bone substitutes involve ceramics, which is our calcium sulfate, calcium phosphate, and a bioactive glass, which is an interesting thing that I've came across while reading up about this. Just to keep in mind, the primary inorganic component of bone is calcium hydroxide. If you ask yourself, when you want to use a bone substitute, what would make an ideal substitute? You want a chemical structure that basically promote bone healing, a structure that will replace native bone, as well as a structure that is mechanically strong to provide stability. So if I go into calcium phosphate, it's mainly used as an osteoconductive matrix. It's a very brittle substance with poor tensile strength. It's used for filling contained bone defects and areas of bone loss. You place it in rigid stabilized bone or intact bone to avoid shear on biomaterial, and is also tightly packed in adjacent host bone to maximize ingrowth of new bone. I've just put some samples of calcium phosphate that we all know about. It comes in porous, non-porous blocks, as well as porous granules. Okay. A little bit about tricalcium phosphate. It's a porous ceramic. It converts partially to hydroxide in the body. It also has a faster rate of resorption, which makes it chemically weaker, and therefore also unpredictable biodegradation, which makes it not that popular to use. Here I've put some pictures of tricalcium phosphate that is available on the market, and most of them are being used in the dentistry. Just a little bit about calcium collagen graft material. It's also a conductive composite that consists of hydroxyapatite, calcium phosphate, type 1 and type 2 collagen. This does not provide structural support, and it is more used for bone as a bone substitute or a bone graft expander. And here I've put a sample of calcium collagen. Is basically, it looks almost like a plug, like a tablet that you put in a filler. A calcium sulfate graft is alpha high hemihydrate crystalline structure. We use it as a bone void filler. It's completely resorbed as a new bone remodels to fill the defect. And here you can see that they've used it in lytic lesions of the bone, where it fills that void, and over time the bone completely resorbs it and refill it with new bone. Then we also get the injectable calcium phosphate. It's basically a paste of inorganic calcium phosphate. It hardens very quickly. Within 12 hours, you get it crystallized to a dull light, which can resorb and be replaced by the bone, by the host bone. It's useful for internal fixation of impacted metaphyseal fractures that we've seen. Prof has also mentioned in the distal metaphyseal femur fractures. And here's just some example of the injectable calcium phosphate. Who is that that's talking in the background? It is made out of a powder that you mix with a liquid form. It forms into a paste that you can inject into these metaphyseal areas to supplement your internal fixation. And another interesting substitute was the bioactive glass, which is basically a composed of silica, calcium, sorry, that's a spelling mistake there, oxide, disodium oxide, and peroxide. So this bioactive glass is, they bind to the collagen and growth factors and fibrin to form a matrix in your body or in the bone. And by doing that, it provides a compressive strength, but not structural support. And here's also examples of it where you basically make a paste of it that get into a syringe, and they've used it in spine surgeries. Here you can see on the post-op, the injection has been, the orange marker basically show where they've injected this bioactive bone, and then 18 months later, you can see how beautifully it has spread and new bone is basically formed in that area. And yeah, it comes as granules as well as a paste. Thank you.